Welcome again, my colleague. In the last part of our session today, we were discussing, I think, the second case with Dr. Akila. What's your differential diagnosis?
The differential first top differential was stage 4 avian, the left side, and also it could be the differential would include inflammatory arthropathy, and if
Like
it
what?
would present usually like rheumatoid arthritis, and
Excellent.
or septic arthritis could be a possibility if there was acute presentation previously.
Excellent,
And
Dr. Akila.
next MRI of the pelvis to be done for better evaluation of the
Okay,
findings.
excellent. Case number 2, 10 years old female patient with chronic left hip pain. I think this case, okay. 70 years old female patient with chronic left hip pain. You can go.
Okay, extra pelvis from the projection of a 70-year-old patient with chronic left hip pain. Here I can appreciate the abnormal angulation of the femoral neck. Also, I can appreciate uh, there is some narrowing or a reduction
What
in
is the
the
name of this
size of
sign? What is the name of this sign?
um, sorry, sir, I can't recall the name.
What will you do next?
I think MRI.
This is MRI.
Okay, on the T1 enlarged coronal base, I can appreciate the large soft tissue uh, around the left femoral head and neck region.
What's your differential
On
diagnosis?
there is extensive soft tissue.
Mm.
Um, it appears hyper intense.
This is post-contrast T2 fat set of the same patient. It's a chronic
Okay.
condition. So tell me, conclude the case and tell me your differential, please.
Okay, on the source contrast, it is showing a peripheral rim-like enhancement of this large
So
soft tissue encircling the proximal femur, and also reducing the femoral neck size. I think this could be inflammatory process, which is
okay,
leading to inflammation of the synovium, and
excellent. What else?
uh,
What else?
um, the PVNS could be one possibility.
What will you do
Pigmented
next?
synovitis. I would compare with the previous one and would refer the case to the orthopedic MDT for discussion and further management.
15 years old male patient with large lower femur swelling.
Okay, this is a frontal projection of a 15-year-old male patient. Um,
This
How I can appreciate abnormal occurrence of the distal metatarsus of the fiber, which is showing some sclerosis of the medullary cavity. Also, I can appreciate the periosteal reaction bilaterally along the medial and lateral cortex. Um, and there is also a appearance of the quadrant triangle along the mid shaft region. And uh, mild soft tissue thickening as well.
what's your differential?
So differential is an aggressive process. Differential would include infective versus a malignant, and I
Could
would suggest
you could you include here infective? Are you sure? On top of your differential diagnosis, which pathology? Tell me one to see.
top will be malignancy.
Like
Second, like
life
osteosarcoma,
and what else?
and Ewing sarcoma.
Excellent. What will you do
Then
next?
MRI of this whole bone, including the proximal and distal joint,
Excellent. What else?
and to see the scapuliums and also the involvement of the joint. Then further, if the MR confirms my diagnosis of malignant lesion, then I would suggest staging CT, chest, abdomen, pelvis, and followed
What
by bone
else?
scan.
What else?
Would refer the patient to the MDT and bone tumor center for biopsy and further management.
75 years old male patient with a back pain.
Also, this is MR of the cervical spine, sagittal view, T1 weighted sequence. This is also including thoracic spine, T2 weighted, sagittal.
Your voice is not clear. Your voice is not clear.
Okay. So now this is a sagittal view, T2 weighted sagittal of the thoracic spine. And
Hmm?
I'm looking multiple areas of abnormal attenuation involving the vertebral bodies.
Hmm?
Uh, the the signal of the intervertebral disc are also abnormal. Um, I'm looking
So
at uh, I think I cannot appreciate any intraspinal extension. Of
you can appreciate in sagittal. In which sequence you can appreciate?
intrathecal.
Yeah, in which sequence better to look for intraspinal extension? In which section?
Axial would be better.
This is the axial.
Mm.
Tell me your differential diagnosis.
I think multiple abnormality and this, sorry, I forgot the age. I think it was young patient, 17. I forgot the age of the patient. I think, yeah,
17 years.
multiple
Hmm.
abnormal
What's your
involving the vertebral
differential?
body.
What's your differential?
Uh, Metastatic disease. In
Which
one
type of
patient,
metastasis and why?
they appear, I think, low signal on T2
Yes.
and
So
so
what?
blastic, osteoblastic mets
Excellent.
would be differential. And
Could you tell
this
me the primary?
in an old patient, if age 60 plus, I think the top differential in a male patient would be prostatic.
What will
If
you
a
do
female
next?
patient is female, then breast. Next will be MR of the pelvis, and would also uh,
Yeah.
I think in
Okay.
bone scans to see the further.
Okay. Okay. 45 years old, post-trauma patient.
This
What's
is
your diagnosis?
this is a mid shaft frontal view of the axial view of the right shoulder. I can see mid
Yes.
shaft with overlapping edges of the right clavicle.
Hmm?
The acromioclavicular joint appear intact. However, this is not a proper view for to evaluate the joint. And
Okay.
there is also a lytic area involving the overlapping fragments
Okay.
of the vessel. And also, I can appreciate the rib fracture involving the third rib posterior aspect. Uh, and I suspect pneumothorax in the right side.
Excellent. Excellent.
Um,
What will you do next?
I would immediately inform my findings to the clinical team and would suggest orthopedic referral and also a CT chest to see uh, further involvement or lung injury or extent of the pneumothorax.
50
I
years
would
old.
suggest if the pneumothorax is large, then immediate intubation should be
Okay.
done to
50 years
prevent
old
recovery.
patient after trauma.
Okay. Okay, this is a frontal view of the 50-year-old patient of the lower leg, including the ankle joint. I can
What's your
appreciate
diagnosis? What's your
Mesonephric
diagnosis?
Mesonephric
Okay.
Mesonephric proximal fibular fracture, overlapping edges, and also distal tibiofibular joint widening. And also there is a widening of the medial joint space as well.
Dr.
Excellent.
Rami, time is
Okay, thank you, Doctora. You did very well in last case. This is Ms. Neveu fracture, and by the way, the name by a French doctor. Ms. Neveu fracture is a very common exam case, but he didn't show you this. He just bring one ankle. When we see a loss of overlapping or enlargement, widening of the medial clear space due to deltoid ligament rupture, we should tell the examiner I should do upper leg X-ray to rule out fibular fracture. Meniscal fracture is very common and very dangerous due to instability of the ankle. You did very well in this last case. There are some measurement here. The medial clear space should be more than 6 millimeter to be abnormal. Also, you should diagnose Mesnevo fracture when you see a loss of the overlapping of the distal tibiofibular joint. Is before this case, I was about not pass you, but at the last minute, you pick up there are new pneumothorax. My colleagues take care when the examiner bring one easy case. Sure, this is a tricky case. Okay, this is a fracture, no problem. But by the way, there are no any lucency here. And there are a visceral pleural rim here. This is a pneumothorax. And this case of pass of fail in each shoulder, film, please look at the lung. Please, please, please. This is osteosarcoma. Uh, I didn't listen till now from all the candidate. This is a sclerotic lesion with ill-defined, with a wide zone of transition. I wanted to listen this buzzword. And in addition, there are not only Codman, there are some set appearance, like here, some laminated periosteal reaction. All of this is aggressive. Second point, يعني it is too difficult to make the osteomyelitis just after osteosarcoma. Make it in the end because it looks like tumoral. Okay, so I must do osteosarcoma, then Ewing sarcoma, because I think this patient is around to close the epiphyseal plate around the puberty. By the way, take care from other types of osteosarcoma, telangiectatic, bariosteal, and periosteal. Take care especially from telangiectatic. It is very tricky. Okay? This case, you take too much time in it. And I ask you about this sign. This is an apple core sign. Apple core sign means there are something chronic here. Okay? Here you pick up well in MRI. You didn't use a CT, and you told me there are uh, synovial inflammation. Okay, or polar or inflation. يعني talk also it may be pigmented villonodular synovitis. Okay. By the way, this case, because it shows some calcification here, Radiopedia diagnosed it as osteochondromatosis. Anyway, the examiner didn't want a full definite diagnosis. He want from you to be aware and the alert about each sign. This is a case of rheumatoid arthritis. You did it very well. You told me there are narrowing, there are erosion, and you talk very well about the possibility of septic arthritis. The difference of rheumatoid arthritis versus osteoarthritis is rheumatoid arthritis show concentric joint space narrowing, but the osteoarthritis showing superior joint space narrowing. I'm waiting from you also to look in each pelvis X-ray. You should tell me about the sacroiliac joint, please, please, please. Okay, my colleagues. Next candidate, and will be the last, I think.
Dr.
That
Sobia.
was in the previous case.
Which one?
Inflammatory. Previous MR pelvis with inflammatory synovium. I thought that
Yeah,
apple core sign was apple core sign was.
Apple Corsani. Yes.
So what was the
Next,
diagnosis in that?
it was osteochondromatosis. Next
Okay.
candidate, ready?
Dr. Sobia Gulrez.
Yes, sir, I'm ready.
Inshallah, today all candidates are attending. Dr. Sobia, how are
Yes,
you?
sir. Yes, sir. I'm good, Alhamdulillah. Shall I start?
Yes, I think we saw it.
Yes, sir, we have seen this case.
Yes. Oh, I didn't talk about this case. This was a sclerotic metastasis. You make a very a fatal mistake here that you forget the history. Sorry, Dr. Akila, to repeat. Because I insisted to tell you 70 years old male patient, and my voice was very loud. And then you get confused, and you told me if female, I will think in breast. No, I told you from the beginning. So I demarcate you to sex. Take care, my colleagues. You told some very good point. This low T2, so I'm thinking in osteoblastic or sclerotic metastasis. Sclerotic metastasis also can come from transitional cell carcinoma or neuroblastoma, medulloblastoma, neuroendocrinal tumors. All of us know if female it is a breast, if male it is the primary would be prostate. By the way, a PET CT now is used for prostatic cancer, but not FDG. It is a gallium plasma PET CT. Gallium plasma PET CT. Shall we start?
Yes, sir.
20 years old female patient, painful knee.
Okay, I'm presented with a CT of the knee, coronal view of a 12 young female patient. I can see there is a lucent lesion involving the distal aspect, proximal aspect of the tibia in the metaphyseal, as well as involving the epiphyseal region with sclerotic margins. There is no significant periosteal reaction. The lesion has narrow zone of transition. There is no periosteal reaction. I cannot see any significant soft tissue swelling. So imaging features are in favor of a benign lesion. Most likely, if this patient has a history of fever, so this could be a Brody's abscess.
Excellent.
However, since this is if this is involving the epiphysis, so my differential would be benign cartilaginous tumor uh, that is also involving the epiphysis. Uh, Sorry, I missed the name of that lesion.
Could,
Chondroblastoma.
could other lesion crossing the epiphyseal plate like this
Yes,
before closure? Yes or no?
yes.
Other
Sorry, sir,
lesions.
I didn't. जी,
Could other lesion crossing the epiphyseal plate before closure like this?
no, sir.
Okay. Next case. Okay. 1 minute. It's years old female patient
Yes.
with a chronic neck pain.
I'm presented with the MRI spine, T2 weighted sequence, digital images. I can see there is a degenerative changes in the spine, predominantly involving the C3 vertebra that is extending into the epidural space. I can see there is abnormal signal intensity area within the spinal cord in the cervical region that is intramedullary, and it has a complete homogeneous low signal range. I would like to see the contrast of this patient.
No need for
MRI.
contrast. This is a chronic since childhood. Look here, please. Look
Yes, sir.
here. Look here.
Yes, sir. I
Look
can't see
here.
the cursor moving.
Hmm?
Yes, sir. Now I can see. Uh,
Hmm?
so this is the there is a myelopathy, abnormal signals within the cord that could, if this patient has a history of trauma, so this could be post-traumatic.
No trauma. This is a chronic condition since childhood.
Okay.
Let me show you old film.
X-ray chest frontal projection.
Mhm.
An
Okay.
adult patient. This is an scanogram. I can see uh, there is opacity in the.
Look at the bone, please. Look at
Okay.
the scapula, please.
Okay. Yes, sir. Uh, so the right-sided scapula is high riding, and
Excellent.
I can also see bone that is joining the scapula, likely omovertebral bone. Uh,
Yes.
I would like to go for the CT if
So,
available.
what is this?
So this is blocked vertebra with
Okay.
degenerative changes that is causing narrowing of the spinal canal, significant narrowing. This is
What is this?
abnormally large posterior
What is
element,
this?
fused posterior lamina of the conjoint vertebra. Uh,
What's your differential diagnosis?
so this is vertebral anomaly that is resulting in myelopathy
Okay,
with the
the myelopathy is almost due to this disc. There are C, 2, 3, 4, 5 discs. Don't worry about it. But
yes, sir.
what is the name of this?
Sorry, sir, I didn't
What
get
is
it.
the name of this bone extended from C3 or 4 down to T1 or 2? Here. What is the name? This bone. Very common name here.
Omo
Yes,
omovertebral
yes.
bone.
Excellent,
Omo-
excellent. Don't worry, don't worry. Excellent. We are here to train.
So
Six
this
years
is
old, 6 years old male patient complaining of right shoulder pain.
yes, sir. This is the X-ray chest. Sorry, X-ray shoulder AP projection of adult male patient. Uh,
Yes,
so there are marginal degenerative changes, as well as I can see that the texture of the bone is somewhat Lucent lesions are seen within the proximal.
Don't worry about it. Look at the humerus, please. Look at it.
So there is an posterior superior aspect of the humeral head. There is
Look at the
yes, there is
subacromial
yes,
space.
subacromial. So there is reduced subacromial space, and it is impinging. The humeral head is impinging the.
What's your differential diagnosis?
So this is leading to supraspinatus tear, and this will lead to like impingement syndrome and rupture of the rotator cuff due to.
Okay, we did ultrasound of the shoulder.
Yes, sir. Sir, I can see this is ultrasound of the shoulder. There is tendinopathy involving the supraspinatus tendon with the fluid collection or tear.
Yes, this fluid collection. So this is
Sir, this is tendinopathy or tear of the supraspinatus tendon, partial tear.
which of them? No. This the whole tendon is replaced by fluid here. So
Okay, so this is complete rupture.
excellent. Okay. My colleague, ultrasound now is very widely used in musculoskeletal, very widely, especially in shoulder. So think and expect you may be given one case. 20 years old male patient, swelling and pain in the anteromedial distal left side.
So there is this is X-ray of the knee joint, left knee joint, AP view. I can see there is soft tissue swelling along the medial aspect of the distal end of
Excellent,
the
excellent.
knee joint. So in my routine practice, I would like to see the lateral other orthogonal view available to see if there is. So this is the lateral view, and I can see there is swelling and edema and loss of the fat.
What will you do next? The bone is normal.
So I would like to
Look at,
yes,
look,
so there is a sclerosis of the distal end of the femur. Uh,
which part
so,
of the distal end?
so the most distal part, the
Yes, which medial
metatarsal
or
region,
lateral? Medial or lateral?
the medial part, and I think there is suspicion of some cortical break as well.
What will you do next?
So I will go to the MRI for further evaluation of this patient. So there are abnormal signal intensity area involving the distal end of the femur and the metadiaphyseal region. I can see there is a soft tissue swelling and a mass lesion that is
Okay.
involving. So this is likely a neoplastic lesion with a wide zone of causation and a soft tissue component. I will
Yes.
inform the clinician as well as. So this lesion is primarily bony and has a large soft tissue component. Um, so in this old age patient, this likely malignant neoplastic etiology.
What will you do next?
So I will recommend biopsy as well as inform the clinician for further management and would like to do staging CT of neck, chest, and abdomen.
Thank you, doctor. I did very well, but like other candidates, try to enumerate your management in the correct logic consequence for a sarcoma patient. First, you will, especially in osteosarcoma, you will image all the limb to rule out multifocal, multifocal osteosarcoma. Second, staging CT. Third, bone scan. Then, finally, you tell I will transfer the patient to a special bone center for open surgical biopsy. Here, here you forget to tell me there are sclerosis here. You pick up this soft tissue. This is very good. But as I told you before, when you see the bone is normal, try to detect any periosteal reaction, Codman triangle, and to look again to the bone. Compare hair with hair, hair with hair. Somebody may told me this is the patella. No, see, this is the rest of patella. Less sclerotic than this. Okay, my colleagues,
Yes.
this case the K in the X-ray. If you see this patient and you reported it as normal, immediately the patient will not undergo any further investigation, either MRI or ultrasound. There are superior subluxation of the humeral head, result in narrowing in the subacromial space. In old age, my differential diagnosis is complete tear of the supraspinatus. This is the ultrasound. See, this is complete fluid here. This is complete fluid here. The tendon is hyperechoic and striated. Okay, this is the muscle. There are no tendon here at all. There are no tendon here at all. There are a large gap. So this is a complete rupture of the supraspinatus. This case, you struggle a lot. No problem because we are now training. But look, I told you many times this is a chronic case since childhood. So I'm pushing you toward the congenital. This is a clival flail. You should tell me, oh, there are blocking vertebra multi-level with rudimentary disc in between. I see a bone extending from the cervical spine down to the lower cervical, the upper thoracic. Oh, this is the homovertebral bone. Okay, and then the case first, the examiner started by X-ray to make you confused by the normal heart, the normal chest, but the pathology is here. Compare this scapula with this scapula. The scapula is elevated, rotated. Oh, this is a springle deformity, and this is the homovertebral bone. So I should compare with the previous, or I should do MRI. Okay?
Okay, sir. So very nice case.
Yes. Thank you. Thank you.
Thank you so
The
much.
previous case, you start very good here, but then you tell me the only aggressive lesion that have a sclerotic margin is the Brody abscess, and the only lesion who cross the epiphyseal cartilage is the Brody abscess. Only. If any colleague know another lesion that cross the epiphyseal plate of cartilage, please tell me. For me, I don't know. I didn't hear about other lesion. So you did very well. You asked about the clinical, the past history of fever, the old images. All of this is very well. Your differential where Brody abscess versus other carcinogenous. But يعني, I think this is a pathognomonic crossing of the lesion through the epiphyseal plate of cartilage is a pathognomonic. Brody abscess, by the way, is not acute picture of osteomyelitis. This is a subacute or chronic. This is very important, which need critage under high coverage of antibiotic, but need critage of the bone because due to this sclerotic margin. If we do MRI, we will see something called penumbra sign, which is a rim of vascularized granulation tissue surrounded an intraosseous abscess cavity. This have very characteristic higher P1 signal in comparison to the surrounding, to the inner cavity. Penumbra sign is a pathognomonic in MRI to the Brody abscess. This case, I think we see before. Anyone have any question? My colleague? Hello?
No, sir. Thank you, sir.
Thank you for all of you. We are trained with us. I want to tell you something about the booking for the slots of 2B. All of us, even me, take 1.5 years to book. So study well, study hard. The only time that you will study hard and keep a good scientific store for your career during FRCR. Don't frustrate it. For those people who didn't get any opportunity, study, continue it. I think I take for 2 years studying. Okay, because of the booking issue. But finally, it make a lot of benefit for me. Thank you for all of you. Thank you, Dr. Mega, too much. Thank you for all candidates. Also, all candidates have common mistake. All of you waiting me and didn't conclude the case. Please, 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 you should conclude the case and don't let the examiner ask you, what's your differential? What's your management? What is the next step? No, try to speak about the findings, then the next step, differential, then management. All of you are talking about too much the finding. Okay, the examiner will not happy if you make an extra finding. He want the full picture. This is for your benefit. Last statement. Stay motivated. You can do it. Thank you for all.
Amigo,
Let's
sir,
meet in.
excuse me.
Yes.
So what is the management of the cases like genetic Sprengel deformity or Klippel field? What management should we tell about them?
Just refer to the orthopedic. No management, no surgical.
Okay.
This is a chronic case and just to enumerate the anomalies. Okay. Thank you for all of
Thank you, sir.
Next
Sir?
week we will meet. Yes.
Regarding the ultrasound case that you shared on WhatsApp, you told we will discuss in the meeting.
But the meeting will stop now. I will discuss as a group. Okay. Sorry.
Thank you.
Thank you, doctor. Thank you. And welcome. I think you are the first time for you.
It's first time. Yeah. Appreciate your help. Thank you. Thank you.
Thank you. Thank you. Goodbye, everyone. Goodbye. Goodbye.